This is what I'm going to go over. I'm going to go over this. Right? I'm going over this. You know what this is? I'm going over chronic bronchitis. You got me? Did I explain to you tension pneumothorax? I did that, right? No? Sucking chest wound? All wounds suck, but this actually, no? Okay, so I'll do that. All right. Okay. I'm going over tension pneumothorax. You got me? So watch. Where is it? Here we go. Somebody stabbed you with what appears to be a bowling pin. It's supposed to be a knife. It's a mess. All right, so watch. You breathe normally. You get air in and out of your lungs through 3 holes, 2 nostrils and a mouth. You got me? So, and if you recall, I explained to you that in the pleural space, there's actually like a little vacuum, like a little negative pressure. And what that does is that keeps the lungs from completely deflating. So remember I told you you can't blow out all the air in your lungs. Remember that? You remember that? Randy, do you remember that? She'll never forget it. Right. I was Facebook stalking her, and she updated her Facebook status with the fact that there's negative pressure in the pleural space. Who would do that? Okay, so watch. Somebody doesn't like you, so let me see if I can do a better job making a knife. There. How's that? That looks like a rolling pin. Now watch. And this is no joke. If somebody has something sticking in their chest, right? Don't go over to them and pull it out. Because watch. You don't cut bread like this. You cut it like this. So the knife cuts both ways. Tell me you're following that. And honestly, if you find somebody like that, what you do is you pack stuff around that little entry wound so that air can't get into it. And then you tell them, you know, call Uber or whatever and get a ride to the nearest emergency room. You can, or ambulate home. So basically what you have done is this. You have created another hole in your chest. And when you do that, don't try this at home. Well, maybe you should. Don't let people see you do this. If you put your fingers on your rib cage, and when you take a breath in, your fingers get farther apart. You got me? So the ribs expand when you take a breath in. So what does that mean when you try to take a breath in? That the hole gets bigger and the wound, that little opening, will suck air into that pleural space. What happens to the distance between the ribs when you blow the breath out? It gets smaller. So this little wound there is like a roach motel, right? The air gets in, it just can't get out. So every breath you take, I'm watching you. Air is going to get sucked into the pleural space and it will begin to compress your lungs. That's the tension. Are you following me? Now, what's in between the lungs? Oh, the heart. Oh. So if this is bad enough, the lung will get compressed, and then it will begin to compress the heart, and you get a condition called cardiac tamponade. And if that pressure is not released, you'll be taking a 6-foot dirt nap. It will be over for you very, very quickly. So what they do for this is this. Watch. This is actually pretty cool. This is actually a dude with a tension pneumothorax, and they're relieving that pressure with what's called a needle decompression or needle aspiration. You did that?
On a cow.
Oh, did you really?
A trocar. They get bloat.
Yeah.
Yeah, and it works.
Yeah, of course. Yeah.
Not me, but my husband and I did it, and it was horrifying. But
Right. You should have videotaped it. I could be
right,
showing
I
that
was
video.
thinking of that. I thought, gee, well, I've got a minute here.
When did you do that?
A couple years back.
Yeah, it's too bad. That was a real good teaching moment there, and you blew it.
Random. If I'd have only known.
So watch. They stick a needle into the chest, and this little doohickey right here, you got me? This thing right here goes into the chest, through the chest wall, and into the pleural space. And if you look, there is a sharp-ended needle there. So it's a catheter over a needle. So the needle is needed to puncture through the tissue, the muscle, and then get into the pleural space. But you don't want that needle sticking in there, because as the lung begins to inflate, you puncture the lung. So they remove the needle, and then there's this one-way valve that only allows air out. And you'll watch the lung re-expand. So this is actually a guy with a tension pneumothorax. And then you watch the lung, it'll start to reinflate. And the lung tissue itself is, it's not real tough. It's soft. It's kind of like stale Jell-O. So if you work in an emergency room and you get a bunch of trauma coming in, then as a nurse, you have to do this. And I've done this a couple of times on people. And then you watch. You want this catheter to be plastic, so as the lung reinflates, it will bend the plastic and not puncture the lung. That's why you remove the needle.
How do you know when it's you've done enough? How do you know when it's full?
Watch. How do you know your tire is empty of air? When you push on the little doohickey for the tire, you hear a sss. Yeah? You will hear a sss as air is coming out of the lung. When you don't hear any more air, there you go. It's reinflated. Then what they'll do is they'll put a chest tube to suction, and they'll keep making sure that lung does not collapse again. And then they take a chest x-ray to make sure that the lung is completely reinflated. And then they remove the chest tube, and then they ambulate home. That's a tension pneumothorax. And it occurs with an open chest wound, usually a sharp object like a stab wound or something like that. A gunshot wound, that can cause a tension pneumothorax too. What's even worse is that you will actually, if they get shot in the lung, it will tear through the lung, so as they're taking a breath in, air will gurgle in through the chest cavity, because that visceral pleura that covers the lungs is now torn and air can escape the lung. So you're a mess that way. So that's tension pneumothorax. Again, the treatment initially is a needle aspiration, and watch. When you were a kid and you farted in the bathtub, right? The fart bubbles went to the surface. So air is going to float. So typically where you start getting the pneumothorax is in the apex of the lung. So that's where you put the needle aspiration, because you know you won't be puncturing into lung tissue. And then a little chest tube to suction. Just so you know, they suture that chest tube in, little FYI. Make sure you cut that suture before you remove the chest tube. Ripping off big hunks of skin, people don't like that. And then you put a little Vaseline gauze there. The Vaseline creates a airtight seal, and then they can ambulate home. And most of them do, because they feel so good. They actually will say to you, I think I will ambulate home. Then you watch them ambulate. Say yeah. How many people got that? Yes? Okay, watch. I'm going over now for you chronic bronchitis. Yes? Here we go. What's the number one cause of chronic bronchitis? It's in the name. What's the number one cause of chronic bronchitis? It's in the name. No, smoking the chronic. The tree. Ganja. Cuckoo for dopal puffs. You guys probably do that all the time, do you? That's why you don't read the textbook. I'm high, so I don't have to read. All right, here we go. Watch. The number one cause of chronic bronchitis is cigarette smoking. You got me? Now, in chronic bronchitis, get this, there's basically three things that happen. Number one, chronic cigarette smoke paralyzes cilia. So what does cilia do? It removes the mucus and bad stuff from the lower airway, and then you spit it or cough it out. Number two, it causes increased goblet cell size and production of mucus. And then finally, the third one is you get bronchospasm. I'll explain that in a minute. Now look. Okay, you have to know this. You have to know this. What are the byproducts of metabolism? Come on. Right? Hydrogen ions, heat. Say yeah. Okay? What do those do to arteries that supply the cells of the body? They dilate them, right? Now, in the lungs, it's a little different. In the lungs, you have these pulmonary vessels. You're with me. And there's a concept called VQ, ventilation perfusion. So please get this. If you send air with oxygen into the alveoli, then you want to send blood to that alveoli that you are ventilating. Do you understand that? So you want to perfuse the alveoli that you are putting air into. So the ventilation perfusion for the lungs should be 1-to-1, meaning every alveoli that has oxygen in it, you should be sending venous blood to it so gas exchange can occur. Say yeah. Are you using all of your alveoli right now? Are you putting oxygen into all of your alveoli right now? No. If you did, then you would have no respiratory reserve. You couldn't get up and move, get short of breath and die. So you're not using all of your alveoli. You're not ventilating all of them. So are you perfusing all of them? No. No. Tell me you better write this down. oxygen in the alveoli cause pulmonary arterial vasodilation. Oxygen in the alveoli cause pulmonary arterial vasodilation. Do you follow this? This is the opposite effect on the cells of the body. Low oxygen, hypoxia, that causes vasodilation to the cells of the body. But high oxygen in the alveoli will cause the pulmonary arterioles to dilate. So, and because arterial blood or blood in general takes the path of least resistance, the alveoli that you are ventilating, you want to make sure that you're sending blood to so that you can perfuse it.
So just
High amounts of O2 in the alveoli cause pulmonary arterial vasodilation. That's why people with emphysema, they're given oxygen to actually cause it. Now watch. Tell me you understood this. You followed this. Yeah or no? Let's try this. Right? Here's a alveoli. Here's a pulmonary vessel. You got me? No oxygen. So what happens to the pulmonary vessel that supplies this alveoli? You're not ventilating it. It is going to remain constricted. Right? But now you are sending oxygen to this alveoli. What does that do to the arteries that supply those alveoli? Causes them to dilate. So when the right side of the heart pumps the blood, where's the blood going to go? Which one will it go through? A or 2? Why? Because it's bigger and it's the path of least resistance. Yes or no? Guys, it's okay. You'll study it. Are you I'm going to say it again. Oxygen in the alveoli causes the pulmonary vessels that supply the alveoli to dilate. If you're not sending oxygen to it, those pulmonary vessels remain constricted. So when the right side of the heart contracts and sends the blood to the lung, the blood that's going to participate in gas exchange is going to go to the alveoli that are getting oxygenated. Okay, good. I'm going to pretend that every one of you got that, and then we're going to move on. You know, I was thinking about this. I was walking down my basement steps, hoping that I would trip, but I didn't. Okay, so watch. I'd like to do a survey before this class starts and ask the students, what do you think we're going to go over? Right? You guys anticipated this, right? Or no? Did you or no? What did you expect? Like it'd go over bones and muscles again? Anyways, maybe that's what I should do, put out a survey. I know, hey, what do you expect? All right, watch. Enough of that. Let's go back here. You have peripheral chemoreceptors and you have the central chemoreceptors in the medulla. Are you with me? If you recall, it is not the direct buildup of carbon dioxide that stimulates breathing, but rather indirectly, or directly hydrogen ions, but indirectly carbon dioxide. Do you remember this? Yes? So it's indirect carbon dioxide, directly hydrogen ions. But watch. In the peripheral chemoreceptors, these peripheral chemoreceptors are especially sensitive to high levels of PCO2, low levels of PO2, and high hydrogen ions or a drop in pH. Are you with me? You're following this? If those peripheral chemoreceptors are stimulated, they will send nerve impulses back to the medulla to tell you to breathe faster and deeper. Do you follow this? Guys? So watch. In people with chronic bronchitis, their problem is this. They get mucus plugs in the lower airways. So this is how it works out for them. You got your little alveoli, and then you're sending blood to these alveoli. And now, what do you got? You got part of your lung, part of your bronchial, the lower airway is full of mucus. Yes? Are you going to be able to ventilate this alveoli? No. You will ventilate this one with oxygen. But the problem in people with chronic bronchitis is they still perfuse those blocked alveoli. Can you see that? So watch. If you can't get oxygen in and remove carbon dioxide, what happens to the carbon dioxide in the blood? It stays in the blood. And if you can't get oxygen in, then the amount of carbon dioxide is going to go up and the amount of oxygen in the blood is going down. Do you see this? Yeah, yes or no? Okay. In the alveoli that are open, gas exchange will occur. You will remove carbon dioxide and you'll take on oxygen. But all of the blood from the lungs goes through the pulmonary veins and goes back to the left atrium. If you are perfusing these alveoli that you cannot oxygenate, the overall carbon dioxide level in the blood is going to go up and the amount of oxygen in the blood is going to go down. Do you see this? For real, you see this? Okay. What happens over time, this is the kicker. This is the, right? Over time, people with chronic bronchitis, they become desensitized to high levels of PCO2. They no longer breathe because of high levels of PCO2. The chemoreceptors, both peripheral and central, become desensitized to high levels of PCO2. PCO2 in chronic bronchitis is no longer the stimulus to breathe. They're chronically exposed to high levels of it. So what happens to the peripheral and central chemoreceptors? They become desensitized to high levels of PCO2. That's recorded right there. Say yes. So you have eliminated one of the stimulus for breathing. So watch. You got 2 left. You follow? You got 2 left. So people with chronic bronchitis, because, wait, the peripheral and central chemoreceptors are now no longer stimulated by high levels of PCO2. They are stimulated, the peripheral chemoreceptors are stimulated due to low PO2, low oxygen. Why do these people breathe? Because of low oxygen. So if somebody comes into the hospital and they have chronic bronchitis and you give them a bunch of oxygen, it will take away their stimulus to breathe. They'll stop breathing. When you stop breathing, you are closer to death. You should write that down. That's why patients with chronic bronchitis are given low levels of oxygen. Because if you give them high levels of oxygen, you have these little chemoreceptors that are responsive to low PO2. If your PO2 becomes high, those peripheral chemoreceptors will say, hey, I'm good. I don't have to breathe no more. And they will stop. I told you about the refrigerator nurse. Did I tell you about that? You know what a refrigerator nurse is, right? Did I tell you that? A refrigerator nurse is a nurse who doesn't work full time, but she picks up a couple of shifts in the ER so she can get money to buy a new refrigerator. That's a refrigerator nurse. They don't work full time, so their skill level is less than the highest quality. So this patient comes in, I don't know, I'm busy doing my thing. And she hooks up to oxygen, turns it on to like 6 liters and walks away. Then I'm doing my thing and I walked past the lady's room and she was doing okay. And then I walked past like 10 minutes later and she's like this. And I counted. She breathed 2 times in a minute. And I thought to myself, watch how smart I am. That ain't right. So I went and looked at her chart, and it was chronic bronchitis for like 20 years. So I went in there, and I turned it down to 2 liters, and lo and behold, she woke up. So you got to know that. Because when you kill people, the hospital really gets upset. Don't want to be doing that. How many people follow that? That is why you don't give people with chronic bronchitis a lot of oxygen. Yay! Can I show you something real quick? This will come back and haunt you, I swear. I'm just going to show you this. Can I tell you, serendipitously, no joke. Yesterday, because I was actually trying to get some year test grades, so I'm grading the multiple guess stuff, right? And then like 3 o'clock in the afternoon, I get hungry. So I'm like, I ain't got nothing to eat. So I'm going to go down to the cafeteria, and I got one of those pizza pretzels, right? Those are good. You should write that down. Anyways, I see 2 students that are in clinical, and I go, hey, how you guys doing? Okay, Tim, can you explain the oxyhemoglobin dissociation curve? I go, why? Well, we have to know it, like a left and right shift and stuff. And I go, no. And I went and I up to my class, graded your test, and ate my pizza pretzel. And the whole rest of the day, I was smiling to myself. because I thought they're going to get that wrong. Isn't that mean? Yeah. That's why I don't stop and talk to students, right? Because they'll start asking me questions. And I don't want that. That's more work for me. What's next? What do we got to go over next? Come on, help me. You don't even know. What's number 10? Okay. Anybody here got kids with asthma? You have asthma? Do you take inhalers regularly? What do you take?
I have the cervic discus and ventilator.
Yeah? Is that good for you? Well, good. I'm glad. Yeah.
If you also want to bridge in 11 is why Adderall is contradictory to the invasions of asthma.
Oh, I'll explain that when I explain asthma. All right. Okay, watch. I'm going to teach you some pathophysiology stuff, right? You got me? Then I'm going to explain some pharmacology. Do you know why? Because I'm cool like that. That's what I'm going to do. Oh, wait. I got this. Here we go. Ready? Look at this. Okay, we're going over asthma. I want this whole thing. Watch. Anybody with asthma has allergies. Asthma is an allergy in your respiratory tract. This is one time where the body does stuff that doesn't make sense. You please get this, right? So what is an allergy? An allergy is an overreaction of the immune system. It's overreacting to something that it shouldn't overreact to. And if you get this right, swig off my Diet Mountain Dew, some little Post-it notes, and a stapler. But for your safety, I'm going to remove the staples. There. What's the primary function of the immune system? It does basically one thing: to protect you. Maybe if I show it to you, that'll inspire you. You could win this.
Inflammatory.
What did you say?
Inflammatory.
That's right. Here, you can have this. It ain't mine. I don't care. Take it. Watch. The primary function of the immune system is to produce inflammation, swelling. That's the function of the immune system. When you twist your ankle, what happens to your ankle? You don't know? Oh, I was hoping that you actually didn't know. Because then what we could do is we could actually maybe push somebody down and then have them twist their ankle, and then we could actually watch it. Oh, yeah. That's what happens. You better get this. Inflammation is produced by the immune system, and there are basically two things that happen. Number one, there is massive arterial vasodilation. You with me? And with this massive arterial vasodilation, you also get increased capillary leakiness. So if the arteries dilate, in the area of your ankle because you twisted it, where's the vast majority of that arterial blood going to go? To your ankle. Say yes. That's why when you twist your ankle and it swells, it becomes red and warm. And it becomes swollen because capillary fluid pressure increases and the capillaries become leaky. So more fluid from the blood leaves and goes into the interstitial space. That's what swells it up. Are you writing that down? No? Are you playing Dungeons and Dragons on your computer? I think that's illegal.
They're from the ones I already wrote up.
Okay, watch. Let's get into this. In asthma, the exaggerated immune response occurs primarily in the lower airways and specifically the bronchioles. And you should know this from general. What are the bronchioles made out of? What? Muscle. And what are the two things that muscle can do? Megan, get this right. And you can have the staples I took out for your safety. And? What did they do? Yeah, that's it. Here, have some staples. When you pick them up, I'm going to turn them over. Pick them up like this. Here we go. Watch. These are the bronchioles. These are little circular bands of muscle. You got me? When the bronchial muscles relax, the bronchioles themselves dilate. Tell me you got that. How many people are with me? You're following this? Okay, good. Watch. Remember I told you I'll never forget it. I explained to you that the lining, whoops, I wanted red. The lining of the respiratory tract is highly vascular. Are you with me? Lots of blood vessels. Didn't I tell you that, Megan? Yeah. She'll never forget it. It was a Tuesday. So watch. I'm allergic to cats. So I see a cat and I'm going to go up and I'm going to pet it. Here, kitty, kitty. I pet it. I suck in a cat hairball into my lung. And I'm allergic to cats. Who's following this? I'm going to get an exaggerated immune response. And what does the immune system do? It produces inflammation. How does it produce inflammation? And I just got done telling you, I'm not even joking. I told you that the respiratory system is vascular. Didn't I say that to you? I'll never forget it. So what happens is this. Is that a result of me sucking in a cat hairball? The little arteries and arterioles that line my respiratory tract begin to dilate. So what's going to happen to the size of my bronchiole, the diameter of my bronchiole? It's going to get what? It's going to get smaller. Tell me you got that. Now watch. Watch. Ohm's flow law, which we know and love. I read a couple tests. That's where some people blew it. I told you that was going to be on there, right? I didn't say that that was going to be on there. Ohm's flow law? What do you mean no? What are you talking about? I told you that was worth like a ton of points too, right? It was not a complicated ant. What are you looking at me? I went over that. Did you all get together like a little conspiracy against Timmy, right? I'm gonna have to actually look at these videos to make sure. Watch. If the bronchial diameter got smaller, what happens to resistance to airflow? Please get this right. It what?
Decreases.
It got smaller.
It increases.
That was your really the only other choice. You got that. So it increases, right? The bronchial got smaller. So the resistance to airflow is going to increase. Yes or no? You see this? Carl? Okay. So what has to happen to systolic blood pressure? What is wrong with me? Oh, that's why you said,
I don't know. I haven't slept all night, to be honest.
I have.
Well, good.
I slept for like 10 hours last night. I actually slept in class, my night class. Said, I'm tired. You're on your own. Can we try to do this? Ready? Cat hair ball gets sucked into your lungs. Yes? You're going to get an immune response. That's going to cause the arteries that line your bronchioles to dilate. So because that lining becomes swollen, the size of the bronchiole decreases. Yes? And Q equals airway pressure divided by resistance to airflow. So if the bronchiole got smaller, the resistance to airflow goes up, so airway pressure has to go up. So in order to create a greater difference between the atmosphere and the pressure in your lungs, you have to create a greater lung volume. That's why people with asthma, they will start breathing like this because they're trying to overcome that resistance due to that inflammation. Yes or no? Now watch. Normally, the air in the bronchiole wants to flow in a laminar fashion like this, layered. But what does the bronchiole have outside its wall? Muscle. So the hallmark, the real distinguishing feature in people with asthma is as a result of this inflammation, it will cause the bronchial muscle to spasm. So the wall of the bronchiole will become wavy and air will no longer flow laminar, it flows turbulently. And turbulent airflow produces wheezing. How many people followed that? Okay, let's see if you followed it. I'm going to write this out for you so you get it. The smooth muscle of the bronchioles has beta 2 receptors. What binds to beta receptors? Epinephrine. The blood vessels, the arteries that line the inner portion of the bronchioles, they have beta 1 receptors. What binds to beta 1 receptors? Good. Epinephrine. Right? Now watch. In beta 1 receptors, when epinephrine binds there, it will cause the arteries that were once like this to now constrict. So what do you do to the lining of your bronchioles? you will make that lining bigger because the blood vessels are constricted. Tell me you got that. The lining is constricting the blood vessels so the airway gets bigger because the lining is vascular. Watch. Watch. I'm going to draw a big tube. A big blood vessel tube. You got me? Here's the blood. Here's all the blood vessels. You got me? Watch. When you inhale a cat hair ball, what do all the blood vessels do? They dilate. They get bigger. So what happens to the size of the hole of the bronchial as a result of the blood vessels of the lining of the respiratory tract dilate? That hole gets smaller. Tell me you followed that. In the blood vessel lining, the cells that make it up there are beta 1 receptors. When epinephrine binds there, it causes the blood vessels to constrict. Tell me you're following this. By the blood vessels constricting, the diameter getting smaller, what happens to the size of the opening in the bronchioles? It gets...
It takes the pressure off.
Right.
Okay.
Tell me you follow. Now you followed that. You got that. Yeah. Yes? Okay, good. What's another problem? You're getting bronchospasms, and that's making the bronchioles even smaller. Say yes. So you're a wheezing fool. So watch. Please get this right. When you are scared and epinephrine's released, what does epinephrine do to all of your blood vessels throughout your body? What? Say that really loud. Massive arterial vasoconstriction. Where? Everywhere. So what happens to the blood vessels that line your bronchioles when you're scared? They get what? Wait, I just said that. That when you get scared, epinephrine's released and it causes massive arterial vasoconstriction everywhere, including the lining of your bronchioles. So the blood vessels that line your bronchioles are going to constrict. They're going to constrict even more. So what's going to happen to the size of the opening of the bronchioles if those blood vessels constrict even more? It gets bigger. Tell me you got that. Watch. Watch. There's beta 2 receptors in smooth muscle of the bronchioles. Are you following? When you're scared, arteries constrict. And what happens to the bronchioles? The bronchioles... They what? They dilate. So watch. When epinephrine binds to beta 2 receptors primarily found on the bronchial muscular wall, it will cause those muscles to relax and the bronchioles get bigger. So, do you see this? Megan, do you see this? So drugs that treat asthma, that cause the bronchioles to dilate, mimic epinephrine. That's why when you take a hit off your Vanillin, you get shaky. And people, because they don't know this, and why would they? They know about Facebook. That's the important stuff. When their kids got asthma, say, okay, Joey, time to take your nebulizer before you go to bed. Then that kid sucks on that, and what does that drug mimic? And they can't figure why he's bouncing off the walls at 2 o'clock in the morning. Because he's jacked up on a drug that mimics epinephrine. Tell me you followed that. Yes or no? Do you have any idea how good that information is? Yeah, you will. Then it'll be too late. No way. Okay, go ahead.
At my work, doctors prescribe nebulizer treatments, like, throughout the day, at night. Some people have them, like, 8, 9 o'clock at night.
Yes.
Why not?
Airways become very reactive at night. 2 reasons. 1, people are laying down. And 2, the airway becomes dehydrated because you're not drinking. So the combination of laying down and the combination of dehydrating the airways make them reactive. That's why they take the inhaler at night. And there's nothing you can do about it. Are you following this? So the drug that causes the bronchioles to dilate is a drug that mimics epinephrine. So albuterol is a drug that mimics epinephrine. What caused this mess to begin with? What is it? An allergy. And what's an allergy? And what's the function of the immune system? Produce inflammation. So what do you know that's naturally occurring in your body? And as a matter of fact, I think it's the only anti-inflammatory you know. It's kind of like Rudolph. Cortisol. So what they will do is they will give you a steroid inhaler, Pulmicort. What is the other one? Pulmicort, Flovent, Combavet, right? Then they came out with some new ones. They came out with Advair. Advair is a long-acting bronchodilator and a short-acting steroid. And you're supposed to take it every day. Here, suck a little powder in there and give it to your friend. Here. Do you follow that? Now watch. This is what people don't understand. And this is if you have kids, now you've been informed. And if you don't do this, then I'm going to have to sick Child Protective Services on you. Do you understand this? Now you've been educated. Before you were ignorant. Now you're going to get educated, right? And if you don't get this, especially for your kid, now you're stupid, right? Now watch. Watch. Kids with asthma go into the emergency room like every couple of months. So what do they do in the emergency room because the kid's having a hard time breathing? They give them a nebulizer, right? They give them the albuterol nebulizer. Then, if it's really bad, they give them IV steroids, usually Solumedrol. And then they send them home on what's called a med dose pack. It's a step down of prednisone. And we know why we step it down. Ain't that right? Then they say, okay, make sure Jasper gets his Pulmicort and his albuterol. But what happens as soon as Jasper starts breathing good, they stop, he's not using the Ventolin, and they stop giving him the steroid inhaler. And that's why every couple of months he ends up back in the emergency room. If you have asthma, bad asthma, you take your steroid inhaler every day. If your kid comes to you and says, Mom, I'm a breathing mother, you say, sit down and take your steroid inhaler. That's why they have recurrence of asthma. Asthma should not recur if it's controlled correctly. You've just been schooled on asthma. Say yes. You followed that.
So, what 2 medications, the albuterol and the
Right.
that you want us to explain?
What other drug?
The A&V, the steroid?
Oh no, watch. You give them steroids which suppress the immune system, and then you give them a drug that mimics epinephrine. Tell me you got that. Ventolin, whatever it is. That's the bronchodilator. The steroid suppresses the immune system so it doesn't overreact. Say yes. You followed this. Did you? Yes or no? Okay. That's asthma. What else I got to go over?
The side effects of bronchodilators.
I just did.
And
Anybody here got asthma? You, Megan, you got anybody else? You got asthma?
I only have like exercise asthma now. Like I only need my inhaler when I exercise.
Yeah, especially when it gets colder out, you have a hard time too, huh? Do you know why? I don't either. I just heard that someplace. Watch. And you typically, you don't get symptoms until after you're done exercising, right? Yeah, because watch. Is exercise stressful? Yes. So when you're stressed, epinephrine's released and it dilates the bronchioles. So you're exercising, right? Your epinephrine levels go up, and then after you're done exercising, your epi levels go down. But if you have exercise-induced asthma, the airways become a little more reactive, and you get symptoms after you exercise. So that's why a lot of swimmers have asthma, and they go into swimming because it's warm and moist. So people with exercise-induced asthma or asthma in general, cold, dry air makes it worse, so they go to sports that are warm and moist, right? Like fishing or swimming or diving or not reading the textbook. Say yes, you got that. You had a question? What was that?
no, I haven't. I got mine after looking and walking pneumonia.
Oh, for real?
I was totally fine, then I got that diagnosed with walking pneumonia, and then ever since then, whenever I was active or out in the cold for too long, I couldn't breathe, and I got done inhaling.
I thought when I was 26, I got asthma. I thought I had AIDS. I was getting night sweats and coughing all the time. Watch how stupid I am. And, this is back in the 80s, right? So I'm like, hey, and this was, right? Because it's so, watch. The big thing now is vitamin D, right? That's a big thing. Well, back then it was AIDS, right? I'm like, hey, So I go to my doctor and I go, yeah, check me for HIV. And he goes, Tim, you ain't got HIV, you got asthma. I'm like, oh, that's good. It's a lot better than having HIV, right? So you know what I did? Back then, before they had phones, I wrote that down. How many people followed that? Yep, that's asthma. Boom. Okay, what else? What else we got to go over? Come on. I want to get this done.
The reasons for increased ventilation with decay.
I didn't go over that? Are you sure? I didn't go. I'm going to go over that. Watch how good this is. Wait, didn't? No, I did. I did. Didn't I?
Yeah. I have it. It's at 9:55.
And you wrote that down, didn't you?
I wrote that down.
I did, for real. If you got time, I'll go over it again. All right, what's next?
What's about the involved?
Oh, watch. Oh, what happened? Hang on. Inderal is a non-cardioselective beta blocker. Inderal blocks all beta receptors. If you have asthma, do you want to block beta-2 receptors in your bronchioles? Do you want that? Why not? Why not? You were just going along with the crowd, huh? Everyone's saying no. Yeah, okay, I'm going to say no too. What do you need to bind to a beta receptor in order to cause the bronchioles to dilate? Right. So do you want to block beta-2 receptors in the smooth muscle of the bronchioles when you have asthma? No, you don't. That's why it's contraindicated. Almost all beta blockers are contraindicated in anyone with asthma. See how that works? Go ahead, look that up. I dare you. Okay, What's next?
It's how CO kills you.
Carbon monoxide kills you?
What is the treatment for carbon?
Well, the treatment is prevention. Don't get carbon monoxide poisoning. Write that down. Carbon monoxide is lighter than air, so it floats. So miners back in the day, they would bring their, like a bird or their ex-wife, and they will put them in a cage up high. You got me? Carbon monoxide, when it's produced, because it's lighter than air, will float. So the greatest concentration of carbon monoxide will be higher up, like in your house. So if you had a bird up there and the bird's vomiting and dying, you need to get your fatty acid out of there. And especially now, too, with you guys turning on your furnaces and stuff. Got to watch that. But let me tell you, people who die from carbon monoxide poisoning, they've never looked better in their life. They have these nice little rosy red cheeks and these ruby red lips, but they are dead. And I'm going to explain to you how it kills you. I gave my night class some extra credit, but they didn't get it right. I forgot to do that. I played this song, and then I played Stairway to Heaven, and I said, you have to guess what question I'm going to go over. So when people, when they try to kill themselves with carbon monoxide poisoning, they usually go into the garage and then put a hose in the tailpipe and then in the window. Don't do that. Just roll your window down and start the car. Because really quick exposure to carbon monoxide poisoning will make you throw up before you die. And who wants to vomit before you die? Am I right? Right? I can think of a lot of other things that you would want to do before you die, like read the textbook. I know what you're thinking, and it's absolutely true. I just will not let that go. I won't. I refuse to let that go. That lack of reading. Okay, watch. Watch. Carbon monoxide is colorless and odorless, so you don't know you're being exposed to it. So you have carbon monoxide, CO, not CO2, and you have oxygen. Carbon monoxide and oxygen compete for the iron on hemoglobin. Watch. In the lungs, oxygen's going to bind to the iron on hemoglobin. You with me? But when it gets down to the cell, that oxygen falls off and goes into the cell. So if the carbon monoxide levels are high enough, carbon monoxide will win and it will bind to the iron. But when it gets down, this blood gets down to the cell, that carbon monoxide doesn't fall off. So every time that blood recirculates back to the lungs, it has the ability to pick up more carbon monoxide. And the more carbon monoxide you pick up, the less oxygen you can deliver. So you asphyxiate yourself, right? You lack oxygen to the brain and you die. That's how they die. But when carbon monoxide binds to the iron, it produces a red-colored blood. That's why they look healthy when they're dead, because it still turns the blood red. So what's the treatment for it? Okay, write this down. What's this? What is that? That's true. You can say this to people. Oh yeah, FiO2. This is fraction of inspired oxygen. Room air is 21%. With room air of 21%, that makes the PO2 in the alveoli 100. You got me? Yes or no? If you give them 100% oxygen, not 21, 100%, the PO2 goes up to about 600. There's more pressure there. So the higher the pressure of oxygen, the partial pressure of oxygen, you can force that carbon monoxide off the hemoglobin. So the first initial treatment for exposure to carbon monoxide is high flow, high concentration of oxygen to try to force that carbon monoxide off the iron.
Unless they have chronic bronchitis.
Yeah, then just forget about it. They're screwed. It's going to be over for them. Then you have to put them on a ventilator. Now watch. If that's not enough, they put you in a hyperbaric chamber, and they crank up the oxygen to 800-900, and then it literally forces the carbon monoxide off the iron. That's how it works. So the treatment is high flow oxygen. If that's not enough, it's hyperbaric chamber. Say yes. Huh? That's like a little, it's a giant sized propane tank that you see out in the county. It's like a big, yeah, you know what a hyperbaric chamber is, don't you? Yeah. Michael Jackson used to live in one.
Do you come out more pale?
What's it?
Do you come out more pale? But I'm fine.
Oh, I get it. He had vitiligo totalis. I don't know what that is, but that's the word of the day. Okay, did I do that? Okay, what's next? Come on, we got to knock this out. What are the questions?
Explain the pulmonary function curve, which curve shows evidence of COPD. Why? I will give you a pulmonary function curve in class. Write your answer on the graph.
You're actually going to give pulmonary function curves? That's nice of you. Right, but here's the thing. That's kind of cheating if she were to give you the pulmonary function curve, huh? Because then she would know the answer. So I'm going to give it to you. Let me just do this, and then you can take a break, okay? Watch. Ready? True or false? And I'll give you a hint at the answer. Is it moist and meaty in the alveoli, or is it dry as a bone? Good. There's water in your respiratory tract. Carl, ain't that right? See? Carl says true. What's that?
Is this real life?
What? I'm demonstrating to you.
That when things are moist, things stick to it.
What? That's a good example. What, you want me to clean the board off? Watch. Please get this right. When you take a breath in, your alveoli expand. True or false? True or false? Good, it's true. Say yeah. When you blow the breath out, the alveoli tend to what? Collapse. Is it moist and meaty in the alveoli? Water molecules cling together. That's why, watch, I can't use this, but I'm going to use it anyways. when you're reading the textbook, to turn the page, you lick your finger. Right? That's because water molecules make things sticky. So when you blow the breath out, the alveoli will collapse, and the walls of the alveoli, because it's moisture in there, tend to stick together. Do you want your alveoli sticking together? No. So in the lining of the alveoli, there are specialized cells called type 2 alveolar cells. And these type 2 alveolar cells produce a substance that prevents water molecules from sticking together. And that substance is called surfactant. Have you ever heard of surfactant? Yes. Guess what? I asked you guys not to do it too on the cardio, and you did exactly what I asked you not to do. And diastolic, and then you wrote and diastolic volume. Right? I asked you not to do that to give me the definition, right? So I just went insane. Watch. Babies' lungs are developed. Do you understand? They're fully developed within the 4th month of gestation. What don't type 2 alveolar cells start producing until about the 7th month? So when the baby comes out and they're premature, the doctor slaps them on the butt, right? And the kid's like, what the, right? Takes a big deep breath in for the first time. They expand their alveoli. But then when they blow that breath out, if they don't have surfactant, the alveolar walls stick together and they go into respiratory distress. Then they're placed on a little ventilator to re-expand those alveoli, and they're actually put on a setting called PEEP. Have you ever heard of PEEP? Have you? You've heard of it? Yeah. What is PEEP?
That's what you're trying to accomplish.
To
The
people?
level of air.
Right. PEEP stands for positive end expiratory pressure. So as the baby is breathing out, the machine puts a little positive pressure. Blowing out, they'll put a little positive pressure to keep the alveoli from sticking together. That's called PEEP. Some nurses who never paid attention to this stuff, they thought it was those little marshmallow treats, and they were sticking them down the ET tube. Tell me you got that. That is surfactant. There's a condition called alpha-1 antitrypsin deficiency where these people don't make enough surfactant. So these people live to the ripe old age of about 40. And I see a lot of them smoking too. That's good. Yeah, I can't breathe, but I'm going to smoke. Yeah, that makes sense.
I'm gonna live at 40.
Well, yeah, I guess you're right. You know, got to go out in style. So we drink old style and smoke. All right, take a break. You guys deserve it. All right, so we did that. Pulmonary function, yes? Here we go. You're going to love this. You guys love pulmonary function. You don't? Where did I put it? Oh, here we go. Okay, write these terms down. This could be a potential gift quiz down the road. Hint, hint. Some of you need gifts. Yes. Want to fight? Ready? I'm not going to give you these definitions. You're going to actually open up your book. I know. That is cruel. That's inspiratory reserve volume. Forced vital capacity. I think in your book they just describe it as vital capacity. And then forced expiratory volume in the first second of time. First second. Right? Forced expiratory volume in the first second. Not first and second, first second of time. You following? Okay. Actually, as I go through this pulmonary function, what you'll find is I will be defining these terms. So that means you might not have to open up that book. All right. Has anybody here done a pulmonary function test? Nobody? So basically what they have you do is they hook you up to this little machine, they put a little nose clip on you, and they have you breathe into this machine. Are you with me, guys? So actually I think I might have a picture of a pulmonary function machine. Whoops. So your job, depending on where you work, will be to interpret these pulmonary function testing, right? Talk to the patient about it. All right, what happened there? You saw that open, right? Oh, here it is. So there's a guy who appears to have a milk bottle in him. Dashed milk bottle. Yes. There's the machine, right? And then it's hooked up and you breathe in and out. Are you following? Now watch. The purpose of the pulmonary function machine is to measure specific lung volumes, to measure how much air you can take in maximally, and so forth. So watch. They will begin to tell you to breathe normally, right? So what they're going to do is hook you up to the machine, you start breathing normally. The amount of air that you take in and out with each breath is called your tidal volume. You got me? And a normal tidal volume is about 500 milliliters of air. So on average, you take in and out of your lungs about a half a liter of air. That's tidal volume. Now watch. After you're breathing normally, they're going to tell you to take a big deep breath in and hold it. So you take a big deep breath in and hold it. The amount of air that you can take in maximally after a normal inhalation is called your inspiratory reserve volume. So you're breathing normally, watch. And then after you take a normal breath in, they'll say breathe in, and you suck in as much air as you can. That's inspiratory reserve volume. Then they're going to tell you to blow that air out as hard and as fast as you can. Are you with me? The amount of air that you can blow out maximally after a maximal or after a normal exhalation, that's called your expiratory reserve volume. So inspiratory reserve, amount of air that you can take in after a normal inspiration, maximally. Expiratory reserve volume, the maximum amount of air that you can blow out or expire after a normal expiration. Yes? Guys? So watch. Ready? The maximum amount of air that you can take in with one breath and blow out with one breath. The maximum amount of air, that's called your forced vital capacity or vital capacity. Yeah or no? Okay. Now watch. This is measured over time in seconds. It should only take you a few seconds to blow out all the air in your lungs. If it takes you an hour, there's something wrong with you. So when they do this, they measure this in time and seconds. So watch. First of all, you're going to measure how much air you can take in maximally and blow out maximally with one breath. Then they're going to look at that curve, how much air you can take in and blow out maximally. Then what they want to look at is how much of that air that you could maximally blow out, how much of that air could you get out in the first second? Yes or no, guys? That's called your forced expiratory volume in the first second of time. Yeah or no? So what they look at is this. They look at the ratio of FeV1, which is forced expiratory volume in the first second, divided by your FVC, or how much air you can maximally take in and blow out with one breath. So let's look at this for a minute. If my nose starts bleeding again, I might have to leave. I'll be back. I just got to stop it from bleeding. Gateway doesn't like when instructors bleed. It's in the handbook. Okay, watch. How much air was dude able to take in and blow out maximally with one breath? Well, look at the graph. Start at 0 and you go 1, 2, 3, 4. And then you trace over the line. So dude was able to blow out 4 liters of air. That's his forced vital capacity. Then you look at how much was of that 4 liters was dude able to get out in the first second. Well, he started here, and then you go to 2, because that would be 1 second. And then you draw up a nice little line, and then you draw it over. So how much air could you get out in the first second? Well, look, if you draw that over, whoops, I moved it. When you draw it over, it comes out to 3. So his FeV1 or how much air he could get out in the first second is 3 liters. What do? You take your FEV1 divided by your FVC. What was his FEV1? Who knows? I'll just tell you. It was 3. How much could he get out total? 4. So his ratio of FEV1 to FVC is 75%. And if you can get out at least 70% of your air in the first second, you have normal lung function.
So is this why, like, if somebody's in the hospital and they give you, like, this thing with, like, a tube on it that you blow into and it's a cylinder and it goes, like, up and down? Is that to, like, help this?
That's called incentive spirometry. They do that because when you're in the hospital, you're sick, and you don't feel good. Are you writing that down? And when you don't feel good, you don't want to move. And when you don't move, you don't breathe as much, so little alveoli start collapsing and you get pneumonia. So they do that incentive spirometry to open up your alveoli so that you don't get pneumonia. This is actually measures lung volume, so watch. Let me see if I can explain this. Probably not, but I'm going to try. Watch. Watch. I'm not even going to ask you. I'm just going to tell you. I would ask students that. I go, do you just want me to tell you? Yeah. I said, okay. So that's what I'm going to do. When you take a breath in, your bronchioles and your alveoli will expand due to that negative pressure in your chest, right? You've increased the volume. When you blow the breath out, there is a natural tendency for your alveoli and your bronchioles to collapse. Do you see this? Right? It's like blowing up a balloon, it expands. When the air comes out of the balloon, it deflates. That was a good example. Maybe we should blow up balloons. Do you want to? Okay, good. So watch. In people with asthma or chronic bronchitis, they can't get air out. Why? That's because the lining of their respiratory tract has become swollen. So it's reduced the size of that opening. So when they take a breath in, their alveoli and their bronchioles still expand, but because that lining is swollen, engorged with blood, the hole is smaller. So when they blow that breath out because of that swollen lining, it will take longer for you to get that air out because the hole is smaller. Nobody's even listening, are they? Okay. Did I tell you I was going to get a GoPro? And then hide it and then show you what I look at? I'll tell you, it inspires me to want to really do a good job when I look at the faces of the students out there. All right. You know what? That'll be on your own. You can figure that one out. What do you say? Okay, did I do that? Pulmonary function. Did I do all of them? Okay, we're done. What's number 5?
To explain the ways oxygen and carbon dioxide is transported in the blood and cells.
I didn't explain to you like the chloride shift and all that stuff? Did I explain that? Carbon dioxide, how it binds to the amino group? No?
I have number 5 right now.
What is it? What do you got?
I just have number 5. No, I am.
Okay, let me go over it real quick, okay? I think that'll be a good idea. What do you think? Should I do that? Okay, I'm going to do that. I'm going to go over how oxygen and carbon dioxide are transported in the blood. All right? Are you ready? Okay, we know how oxygen is transported in the blood, right? Right? It's transported, dissolved in the plasma, and bound to the iron on hemoglobin. Right? We established that. That's the two ways oxygen is transported in the blood. Right? We went over, right? Okay. Now I'm going to go over carbon dioxide and how it's transported. It's a little more complicated. The devil's in the details. Here we go. Okay. We know that a byproduct of cellular metabolism is carbon dioxide, PCO2, right? We know that the partial pressure of carbon dioxide in the cell is 45, and the partial pressure of carbon dioxide in arterial blood is 40. So by pressure, carbon dioxide will move from the plasma into or from the cell into the plasma until the partial pressure of carbon dioxide in the cell equilibrate. They're equal, right? So as PCO2 begins to build up in the blood, carbon dioxide will diffuse from the plasma into a red blood cell, in the cytoplasm of the red blood cell. Because there's water in the cytoplasm of a red blood cell, it's going to combine, CO2 is going to combine with water, and it's going to form our buddy, our pal, the one and only carbonic acid. Carbonic acid will then dissociate into free-floating hydrogen ions and, of course, bicarbonate ions. And these bicarbonate ions have a negative charge. If these hydrogen ions remain free-floating, they will affect the pH. So hydrogen ions get loosely bound to hemoglobin. Therefore, hemoglobin acts as a chemical buffer. Remember that law of electroneutrality? Remember I explained that to you? And I said that if a negatively charged particle, in this case bicarbonate, leaves the red blood cell and goes into the plasma, a negatively charged particle from the plasma has to enter the red blood cell. So that's how chloride enters. This is called the chloride shift. The purpose of the chloride shift is to maintain that law of electroneutrality. Now, the other portion of carbon dioxide does not compete with iron, but rather binds to the amino group on hemoglobin, producing carb amino hemoglobin. So if you were to look at the three ways that carbon dioxide is transported in the blood, the first way is dissolved in the plasma as PCO2. The second way is bound to the amino group on hemoglobin. And the third way is bicarbonate. Now, again, I'm going to say this. I'm going to stop and I'm going to say it real clear. Do you guys look at these videos? Okay. If you list PCO2, the amino group, and bicarbonate, and you don't explain how you get bicarbonate, you're not getting any points. Do you understand that? I don't think I can be any clearer than that, Carl. Do you? Good. I want this explained to me. Say yeah. Wait, it's not over. It gets better. All of that blood that's now rich in carbon dioxide has to come back to the lungs. You got a red blood cell. You got hemoglobin. Yep. You got that amino group that you have carbon dioxide bound to. You got bicarbonate, you got chloride in here, and then you got bicarbonate floating in the plasma. Yeah? Then you got the little hydrogen ion kind of nestled up to the hemoglobin. And then you have the PCO2, which is 45. The PCO2 of the alveoli is 40. So by pressure, carbon dioxide is going to leave and go into the alveoli. Now, as PCO2 begins to drop, that's going to cause bicarbonate to come back into the red blood cell. And to maintain the law of electron neutrality, chloride will leave. Bicarbonate's a base, so it's going to change the shape of hemoglobin slightly, and it's going to cause that little hydrogen ion that was nestled up to fall off, right? And it's going to combine with bicarbonate to form carbonic acid. And then that dissociates into carbon dioxide and water. And then the CO2 diffuses, boom. That's how you transport carbon dioxide. Just so you know, that question is worth 250 big ones and no little ones. There you have it. Okay, are we done with the respiratory system? I think we are. Yeah? Did we do anything? Did anything else that we didn't do? Did we do it all? Did I do it?
So the pulmonary function curve is the small vessel one?
No. I'll let you know. You don't need to worry about that. Not right now. You have a midterm to worry about. Ain't that right? Okay, we're done with that. I'm going to start the kidney, yes? Ever onward. The kidneys, people don't like the kidneys. How many people like the kidneys? Anybody? Who's a big kidney fan? Carl, you look like a big kidney fan. Right, you work in dialysis. Right? Oh. Maybe you should be up here talking. Do you ever give them bicarbonate? Yeah. I wonder why that is. Okay, here we go. Ooh, a lot of stuff going on. Okay. The kidneys have a ton of functions. Again, the kidneys are kind of like the stepchild of the body. Nobody talks about them unless they do something wrong. You know? Let me erase this. Okay. Let's go. First of all, you have two kidneys, right? Right? And a left kidney. Why is the right kidney lower than the left? Is this a male or a female? Right. So when they were taking the picture, she was kind of upset, so she was like, so that's why it's lower. What's right here?
Liver.
The liver. That's why it's lower. So the right kidney is actually a little slightly smaller than the left. All right, so watch. A quick review of the urinary system because you covered this in general, right? The urinary system consists of the kidneys, the ureter. What are the ureters made out of? What? Muscle. And what are the two things that muscle can't do? Don't you wish that was a question on the midterm? Yeah, maybe I should add that. Okay, yeah. And just think if you got that. You'd be so happy. Okay, as long as you got it right. Okay, ready? Watch. Does urine slide down the ureter? It's like a big water slide. Does it just flow down into your bladder? Yes or no? Does food slide down your esophagus? Does it? It moves it through peristaltic waves, right? So if you stood on your head, then all your stuff, your fruity pebbles and everything, come right out. Do you follow that? So if you stood on your head and urine just slid down the little ureter slide, then urine would back up in your kidney. You don't want that, do you? So how does urine that's formed by the kidney get into the bladder? It rhythmically contracts and pushes the urine into the bladder. Tell me you got that. You followed that. That's called peristalsis. Do you remember that from general, right? What do you remember from general? Nothing.
Kidneys, right?
Yeah, you knew what those were. Darn it. Yeah, okay, that's something to build on. Okay. Watch. I'm going to show you something. Do you know anybody who's had a kidney stone? Those are bad. I had, when I was working in Dallas, there was this guy, he came in crawling into the emergency room, begging for morphine. He had a kidney stone, right? Then after we gave him some morphine, he goes, Tim, I was a fighter pilot in Vietnam, and I got shot down, and I was in the Hanoi Hilton for 2.5 years, and they tortured us, pulled your fingernails out, all that stuff. He goes, that was nothing compared to that kidney stone. Now, they say that if a guy gets a kidney stone, it's analogous to a woman giving birth. So I'm now going to prove to you why guys are smarter than women. When a guy gets a kidney stone, he don't want another one. I'm giving myself a high five for that one. Here's the other thing. Watch. When you form a kidney stone, listen up, because this is true. They're not like little round Piri boulders, right? They are like ninja Death Stars. And those little points of those renal calculi dig into the ureter, and they get stuck there sometimes. And every time the ureter contracts to move the urine down, it produces these waves of pain called renal colic. That's why. Tell me you followed that. Now watch. The ureters are made of muscle, right? They're made of muscle. So can they expand a little bit? Can you stretch the muscle a little bit? Sure. So by adding more urine to the ureter, you can actually stretch out the ureter in an attempt to get that stone passed. That's why doctors will tell you if you have kidney stones to drink beer. That's no joke. So I drink beer as prophylaxis against kidney stones, protecting them. Are you follow? Do you guys know what gout is? Do you know? Have you ever heard of gout? You get a joint? Yeah, watch. Yes. Ooh. Ooh. I don't want to see that. Can you get a picture of it, though?
No.
Oh.
He's actually going for surgery.
Oh, watch. Do you eat DNA? That's not obscene. Do you eat DNA? Wait a minute. Do you eat DNA? You don't eat DNA. You've never had a steak before in your life? Never? You're, if you eat animal meat, you are eating muscle. And muscle has a nucleus that contains DNA. Tell me you got that.
What about seeds?
What about what?
Seeds.
Yeah, like yeast and stuff, right? So muscle contains DNA, yes? So do you eat DNA? Yes, you do. So that DNA, when you eat it, gets into your digestive tract and it gets broken down by your liver, right? And you take those nucleic acids. Oh, this is building on this. Yeah, previous knowledge. You take those nucleic acids and they go to the liver and they will get broken down to uric acid. Uric acid is insoluble in the blood. It forms a precipitate. Watch. If you put a penny into this Diet Mountain Dew, where does it end up? On the bottom. So that uric acid forms a crystal and it precipitates out of the blood. And the most dependent part of your body is typically your big toe. So those crystals will start lodging on the joints of your big toe and you get gouty arthritis. People who have gout have an increased risk of developing kidney stones because uric acid is removed via the kidney. So if you drink beer and you eat meat, right, you're at risk for developing kidney stones too, and gout. So you'll be a mess. Your toe will hurt and your kidneys. You don't want that. You want to read the textbook. Go to Gateway. Okay, watch. What's the definition of a bladder? What's the definition of a bladder? Get this right, and I'll give you a gift quiz that's so easy. Like, just write your name. Yeah, now look, everybody. Too late. It's a hollow muscular organ. The gallbladder is a hollow muscular organ. The urinary bladder is a hollow. What are the two things that muscle can do, Megan? She's got it. So watch. When your kidneys make the urine then travels through the ureter, and the openings to the ureter are actually at the bottom of the bladder, and that urine starts bubbling up. You got me? And notice I'm making it yellow to help you learn. So watch. The bladder has baroreceptors in it. Baroreceptors respond to pressure. Did you know that? So watch. Here comes Kenny. There's Kenny from South Park. Don't that look like Kenny? Then we have a dude who looks like that from the movie Tron. Remember? All right. Watch. These are the openings to the ureter, so they open at the bottom of the bladder, and then the urine starts bubbling up. You follow? Now watch. You have pressure receptors in your bladder called baroreceptors. Baroreceptors, pressure. And as the bladder begins to fill, the pressure is going to increase. And you have two sphincter muscles. Sphincter muscles are circular bands of muscle. You're following. You know this, right? You have an internal sphincter that is under autonomic control, meaning when the bladder hits a critical pressure, that internal sphincter relaxes. Say yeah. But then you have an external sphincter that's under conscious control. Let me give you an example. I'm going over this stuff and you say to yourself, I have to pee, but this stuff is so interesting. There's no way I'm leaving. So I'm going to tighten up my external sphincter and listen. Tell me you got that. So women, as they age, guys too, they can't tighten that external sphincter up, so they dribble all over the place. You're just dribbling and there, boom. Say yeah. And then you can always tell when a little kid has to go too. They're playing with their Lincoln Logs and they're like, and they gotta go. And you do it too, don't you? Right? You're like, I'm getting the hell out of here. Right? I know I gotta pee, but I'm gonna make it home. Then you start driving, and then you're doing okay. You hit a bump, well, you know, all right. Then you get to the, like, you pull in the driveway, and you're like, I'm not going to make it. Then you're fumbling with your keys, right? And I'm like, oh, my God. You know it's true, right? See, what I do, man, I just end up going on the side of my garage. I'm like, I know I ain't going to make it. Women can't. One time, me and my ex-wife drove from Chicago out to Denver. And then she's like, I gotta pee. And we were by all these sunflower fields. That's all you saw. And I go, well, I'll pull over, and then go pee. So there's no cars around. So she's peeing, right? And then this car's coming, so I pulled up. Women have that ability to turn that thing off like a freaking faucet. It's like, boom, gone. You're not peeing anymore. You start peeing a guy, that ain't happening. Right? So guys, you just keep going. They don't care. What do women do on a boat?
Jump on the lake and pee.
Oh, is that what you do?
Yeah.
Oh. Guys got it so much better. They really do. But it's tough. Because me, I can't imagine like going to a baseball game or something like that. Or like even like you're out in the woods or something. It's like you just pee. Women, it's like a whole event. Plan for all that stuff. Okay, watch. Here, where's the uterus? The uterus actually kind of folds on the bladder. You got me? It actually kind of lays on top of the bladder. So as the little kid starts growing, it puts pressure on the bladder. That's why women have to pee every 2 seconds when they're pregnant. So don't get pregnant. Study the book. Okay, watch. The external sphincter is under conscious control. If you are a quadriplegic or a paraplegic, can you pee on your own? No. So this external sphincter remains contracted. Tell me you got that. They still have the reflex of relaxing the internal sphincter, but the external sphincter remains contracted because you have to consciously relax it to go pee. So these people, if you're a paraplegic, they have to cath themselves every couple hours, or if you're a quad, then you have to have a Foley catheter in there all the time. Tell me you followed that. So that's how that works. All right. Okay, I'm going to go through the functions of the kidney. I'm guaranteeing you that this will be on the kidney quiz. You're going to know the functions. And this is really important. This is really important. When an organ fails, all the functions of that organ fail. You know that, right? So watch. You can now, if you know the functions of the kidney, you will be able to predict what will happen to this person. Isn't that incredible? Okay, watch. First one. The kidneys get rid of metabolic waste. What is the metabolic waste that they get rid of? You should know this. I sound like a nursing instructor. You should know this. What are they? What are they? Don't know what that's going to do, but it's kind of scary, huh? It's like a ray gun. Disintegrates you. Come on. What are the metabolic waste? Here you get it right. Everybody gets extra credit. Guess what? Nobody's getting any extra credit. What is it? No, you don't. You're reading. Oh, that's good, though. Yeah, you're reading. It's good. And what else? Yeah. But she only got the extra credit for the class. You don't. If I would have asked you, then you would have got it. Ready? Watch. What are the metabolic waste? Blood urea nitrogen and creatinine. I want this. You're going to learn this. Watch. Do we store a lot of amino acids in our liver? No. Good. Right? So when you eat protein, those amino acids are digested. They're broken down into amino acids. And amino acids have this, the NH2, called the amino group. Those amino acids go to the liver. And the amino acids get that amino group hacked off. It's called deamination, right? That's something that you do at church. You're a deaminator. You ever heard of that? Can I tell you something? I'm Irish Catholic, right? I was an altar boy, if you can believe that. Yeah. Lighting those candles, you know. Watching all those old ladies fall asleep at the sermon. Right? They'd be nodding hard, man. Be like, boom. Watch. The liver hacks off the amino group, and it gets converted to this. What's this? Ammonia. Good for you, bad for you? Bad for you. So the kidneys take that ammonia and convert it to urea. Can you breathe out urea? No, so you have to filter it out of your kidney. So there's also a little bit of ammonia in there, so the combination of urea and small amounts of ammonia, because they both have nitrogen, are called blood urea nitrogen. Say yes. Okay, watch. Do muscles store ATP? Yeah, that's right. What are you eating, a banana? That's like brain food. I'm going to make A&P juice over the weekend. Start selling it out of my Jeep. Okay, watch. Wait, what am I doing? I know exactly what I'm doing. This is a muscle cell. Do you store ATP in the form of ATP? No. Good. You're killing it. You store it in the form of creatine phosphate. Do you remember this? Guys? Creatine is then metabolized to creatinine. And creatinine then gets dumped into the blood and is filtered by the kidneys. So what are the two blood tests that will indicate kidney function? Blood urea nitrogen and creatinine. Which one is the best indicator of kidney function and why? Which one is it? Megan, get this right, and here, I'll give you the cap off my Diet Mountain Dew. Yeah, oh here, you can have a calculator. Where's that from? That's from quiz number 1? Oh. Good, you did good. See? Maybe I should ask you questions and then make you read. Do you remember that stuff when you read? Sure. Okay, so watch. Creatinine is really the best indicator of kidney function because your muscle mass doesn't change much. So who has a higher creatinine level, men or women? Men, because most guys, for the crowd, got more muscle than women. Not always. Tell me, so that's why creatinine is considered the gold standard. How come nobody likes that? Okay. So the metabolic waste the kidneys have to get rid of are urea, ammonia, and creatinine. Those are the metabolic waste. CO2 is removed via the respiratory system. The other thing that the kidney does is it maintains electrolyte balance. I'm just going to tell you this, and then when we get to the nephron itself, I'll explain it. Potassium has to be pumped out of the blood. When your kidneys fail, anytime you have to pump something, it requires energy. So the parts of the kidney that fail first are the ones that require the most energy. So in people with kidney failure, their potassium level goes up. So dialysis techs have to worry about the patient's potassium. Do you worry about it or just the nurse?
It's more or less the nurse because they're the ones that actually have the documentation from.
Yeah. But so these people can develop hyperkalemia very quickly. Write this down too. Hydrogen ions cannot be freely filtered by the kidney. They too have to be secreted or pumped out. So that's why nurses worry about the pH, and that's why they mix up bicarbonate, because bicarbonate and hydrogen ions, they will buffer. Ain't that right? See? And I'm not even a dialysis tech. So there. Are you with me? You're following this. So the two things you worry about, at least initially, when someone's going into renal failure is a metabolic acidosis and hyperkalemia. Because those things have to be pumped out. And if they have to be pumped out, when people's going into kidney failure, the parts that require energy are the things that go first. The other thing we already know. We already know this, don't we? Don't we? Don't we? What am I going to write next? What? Yeah, pH. Who said that? I didn't even see your lips move there. You could be a ventriloquist or something. An A&P ventriloquist. Could have me, a dummy of me. Yeah, mark your whole life wrong. That was odd. It maintains pH. Watch. If the kidneys fail, your pH is going to be in trouble. And know this. Write this down. Become an active part of your learning. Randy, write this down. I don't care where you write it down. You are so far from this class. You're not even here. You're like 9 miles away right now, aren't you?
I'm listening to you, just don't like to write because when I write, I don't listen. You told this material.
Yeah, well, I'm changing my tune now because this is so important. Watch. The kidneys can correct any pH disturbance if you live long enough. So any pH imbalance in the body can be corrected by the kidneys if you live long enough. That's why when people go into shock, one of the things that they will do is they will put these people temporarily on dialysis to get their pH back to normal. So if you ever work in the ICU and people are going bad, they will go on temporary hemodialysis in an attempt to maintain their pH. Right, that's... yeah, the glomerular filtration rate thing, yes. See, you think I make this stuff up. I don't, as far as you know. Okay, got a couple of more. Watch. The kidneys also maintain long-term blood pressure through a simple mechanism called these are the initials. Called. The kidneys maintain long-term blood pressure through a simple mechanism called. Come on. Courtney, get this right. What is it? P. Diddy. Pressure diuresis. Right? Anytime your blood volume or blood pressure goes up, the kidneys will produce more urine. So if you drink water, say yeah. All right, watch. That's why when you are here in school and it's nice and warm, and you go outside and it's cold, what happens? The cardiovascular system will constrict the blood vessels to your skin. That's why when you get in your car, now I got to pee. Because your blood pressure goes up and now you got to pee. Right? So do me a favor. Text me or email me when you go into your car if you have to pee. I'm doing a study on that. So the kidney maintains long-term blood pressure through a simple mechanism of pressure diuresis. There are hormones that affect the kidney, which I will clearly elucidate to you, but I'm going to tell you now, right? One of them is aldosterone. We had a little supplementary, very cursory look at aldosterone. We'll go into more depth on aldosterone. Then you have ADH. ADH stands for antidiuretic hormone. Antidiuretic hormone What does a diuretic do? It makes your blood volume go down by urinating more frequently. Tell me you got that. So a diuretic makes you pee more than you should. You got me? If you're an anti-diuretic hormone, what you going to do? You're going to pee less. So ADH, anti-diuretic hormone, makes you hold on to water. And then the other hormone is A&P, atrial natriuretic peptide. Those are the three hormones that affect the kidney, and they will affect fluid and electrolyte balance. That's another function. Another function of the kidney, lots of functions of the kidney, right, is the kidney, write this down, monitors oxygen saturation of red blood cells. So if the kidney detects a drop in the oxygen saturation of red blood cells, the kidney releases a hormone called EPO. You ever hear of EPO? Well, I'll tell you what it is. It's called erythropoietin. Eryth, red, poietin, not eating well. How you eating? Po-eating. Puns are the lowest form of humor. I've hit rock bottom. Poietin means to form. So it's a hormone that will stimulate the bone marrow to make more red blood cells. Say yes. So one of the problems of people going into renal failure is they become anemic. Because remember, when an organ fails, all the functions of that organ fail. Ain't that right? So the amount of EPO that is produced goes down. So what's his nose? Jasper. Live Strong. Lance Armstrong. He was taking EPO. They believe that's what causes cancer. So he was injecting himself with EPO so his red blood cell count would go up even higher. Can you believe that? I don't. I read the textbook. Okay, here's another big function of the kidney. Right, big function. Real big. The kidney activates what? Come on. Yeah, what vitamin? What? What vitamin does the kidney activate? Huh? Vitamin D. What do you need vitamin D for? Absorb what? Nope. Vitamin D is required to what? Come on. Yes. Absorb calcium from the gut. It's also involved in depression as well. Low vitamin D leads to depression. And low vitamin D also discourages students from reading the textbook. So what I'm going to do after your final or your midterm, I'm going to draw a vitamin D level on everybody and check it. That could explain the lack of reading of that textbook. What do you think? No? All right. So with lack of calcium, these people in renal failure develop osteoporosis. So they have really thin bones. So they're encouraged to go outside, especially like on a day like today, down by the lake, and then lay on the rocks and get a tan. Those are the primary functions of the kidney. Say yes. That question is going to be on there. I'm not even playing. All right. Let me do this, and then you can ambulate home because you guys aren't listening. Maybe you are. I don't know. Are you? People don't like the kidney. You like the kidney? No. See. And you said that really with really kind of disgust in your voice. Like, no. You know. It's like, do you like cleaning up vomit? No. Right? Okay, watch. You're going to get this right. I have confidence in you. How much blood does the average adult pump each minute? Right. And you know what? I left the liter per minute off because I knew if you saw that 5, you would go right to it. Watch. On average, every minute at rest, Maria, every minute at rest, you send about 20 to 25% of your blood flow to both kidneys. Are you with me? So to keep the math simpler, let's say it's 20%. How much blood is filtered by the kidneys every minute? Huh? Right. So how many liters are filtered every minute by the kidney? What? That's exactly how you're supposed to say that. 1 liter per minute is filtered by the kidney. You got me? How many minutes are there in an hour? I'm writing that down for sure. So every hour, both your kidneys filter 60 liters of blood per minute. Yup. How many hours are there in a day? Tuesday, Thursday, it feels like 64. Yeah, I'm going to remember that. So if you multiply 60 by 24, that comes out to like 1,440 liters per day. Do you pee 1,440 liters of urine each day? Good. So what that means is, even though that blood is filtered, whatever is filtered by the kidney, 99% of it gets reabsorbed back into the blood. Tell me you got that. Yes or no? Guys, let me just introduce this guy and then ambulate home. And if you send me any emails, I probably won't get to them this weekend because I've got a ton of quizzes I got to grade. Yeah. I'll probably get everyone's graded except yours, Kira. Watch. And I'll be perfectly honest with you guys. This is because the people don't understand, at least at a basic level, how the kidney works. That's why they struggle with the acid-base balance in that fluid and electrolytes class, because they just don't get it. And you need to get this, and I'm going to make sure you get this. All right? What the heck happened there? Watch, it's going to do the same thing. How come it's doing that? Huh? How do I make that thing smaller? Yeah.
What you just did in reverse.
What I just did in reverse?
You grabbed the corner and you stretched it out.
No, I know that. Hang on. Oh, okay. Just don't pack up. Actually, listen to this. This is good. Or you can read it in your book. Good luck with that. All right. Watch. This is the nephron. The nephron is the basic functional unit of the kidney. Are you following me? No? This is where the blood is filtered. I would write this down. I'm not even kidding. Don't listen to what I said the other week. Write this down. If you write it down, I'm not even kidding. Write it down on your forearm or something where you're always going to see it, right? Definitely don't write it in the textbook, Carl. You'll never see it. So watch. Only the plasma is filtered by the nephron. Watch, and this is straightforward. Should you ever have red blood cells in your urine? No, never. Should you ever have big freaking protein albumin in your urine? No. Should you ever have white blood cells in your urine? No. What should be in your urine? The plasma. And what's plasma mostly made out of? Water. So if you're peeing dust, you better go see a doctor. So if you have blood in your urine, you have pus in your urine, or you have big freaking albumin in your urine, something's wrong with your kidneys. Because the only thing that is filtered by the nephron is the plasma. Now watch. Watch. I'll get into a little more detail. Just let me tell you this. This is where the plasma is filtered in the nephron. This little guy is called the glomerulus. And in Russian, I think, it means ball of capillaries. So what's the glomerulus? It's a ball of capillaries. All you have to think of the glomerulus as is a spaghetti strainer. When you make spaghetti, what do? You boil water, then you put the spaghetti in there. Then you check it every couple minutes. Okay, I think it's good. Then you take a spaghetti strainer, you put it in the sink, and you dump the spaghetti into the spaghetti strainer, and all the water and stuff that you put in there drains out, and you're left with the spaghetti. Say yes. Yes? So the big stuff in the blood is caught by the glomerulus. It should never be found in your urine. And if it is, you're in trouble. Say yes. Okay, one more thing and then ambulate home. How many people have ever cleaned a closet in their house? Maria, you have? Okay. Good. You get a check plus for cleaning. Yeah. Watch. When you clean a closet, how do you clean it? Courtney, how do you clean your closet? That's exactly what you do. You take everything out, and then you decide what you want to put back. Tell me you got that. So the nephron filters all of the plasma. And then, as that plasma goes through the yellow brick road, follow it. As that plasma goes through the yellow brick road, the stuff that the body needs is brought back into the blood. And the stuff that it doesn't need gets peed out into the toilet. Tell me you got that. So I'm just going to say this and then go home. Please, don't study for the midterm. You should know that stuff already. The nephron does three things. It filters, and it filters the plasma of the blood. Then, when the plasma is filtered, what the body needs gets reabsorbed. Now watch. And this is the definition of reabsorption. You eat something, it gets digested by your digestive tract, and then it gets absorbed into the blood. If it's in the blood and then gets filtered out of the blood and then brought back into the blood, it's reabsorbed. Did you follow that? And what is not reabsorbed and what can't be filtered by the plasma has to be actively secreted out of the blood. So the process of filtering, reabsorbing, and secreting in the nephron produces urine. And after your midterm, so on Thursday, I'm going to hit this hard. You're going to have to know this stuff. You have to know this. People don't, so they don't do good. The kidney? Yes. Yep. And I got blood gases up there. We're going to learn about blood gases. Yep. And if you don't, well, you'll just get that wrong. All right. Okay. Make sure you show up early on for your time, like 10 minutes early, 5 minutes early if you can.